This is the seventh part of the ECG tutorial from Dr. N.S. Mani, and let us continue with the presentation. In this I am going to talk something about acute bundle branch block seen in myocardial infarction. Acute myocardial infarction in the presence of bundle branch block carries a much worse prognosis than acute myocardial infarction with a normal ventricular conduction. This is true both for patients whose bundle branch block precedes the infarction and for those in whom bundle branch block develops as a result of the acute event. Thrombolytic treatment produces dramatic reduction in mortality in these patients, and the greatest benefits are seen in those treated early. It is therefore essential that the ECG identification of acute myocardial infarction in patients with bundle branch block is both timely and accurate. Left bundle branch block. Left bundle branch block is most commonly seen in patients with coronary artery disease, hypertension, or dilated cardiomyopathy. The left bundle branch usually receives blood from left anterior descending branch of the left coronary artery and from the right coronary artery. When new left bundle branch block occurs in the context of an acute myocardial infarction, the infarct is usually anterior and mortality is extremely high. The electrocardiographic changes of acute myocardial infarction can be difficult to recognize when left bundle branch block is present, and many of the conventional diagnostic criteria are not applicable. Abnormal ventricular depolarization in left bundle branch block leads to secondary alteration in the recovery process. The earlier article about bradycardias and atrioventricular conduction block has been discussed in this video presentation. This appears on the electrocardiogram as repolarization changes in a direction opposite to that of main QRS deflection, that is appropriate discordance between the QRS complex and the ST segment. Regarding this appropriate discordance, I will deal with in another video session. Thus, leads with predominantly negative QRS complex shows ST segment elevation with a positive T wave. That's an appearance similar to that of acute anterior myocardial infarction. The recognition of acute ischemia. Many different electrocardiographic criteria have been proposed for identifying acute infarction in left bundle branch block, but none has yet proved sufficiently sensitive to be useful in the acute setting. However, some features are specific for indicators of acute ischemia. ST segment elevation in association with a positive QRS complex, or ST segment depression in leads V1, V2 or V3 which have predominantly negative QRS complex is not expected in uncomplicated left bundle branch block and is termed inappropriate concordance. Inappropriate concordance strongly indicate acute ischemia. Extreme ST segment elevation, that is equal to or more than 5 mm in lead V1 and V2, also suggest acute ischemia. If doubt persists, serial electrocardiogram may show evolving changes. Now look at this exercise number 1. I will give you total 30 seconds. Please make a diagnosis. Okay, that was acute myocardial infarction and left bundle branch block. Note that the ST segments are elevated in lead V5 and V6, that is an inappropriate concordance, and grossly elevated, that is more than 5 mm in V2, V3 and V4. Note also that the ST segment depression in lead 3 and AVF. Now this is a 68-year-old man with chest pain. What is the diagnosis? And that was ST segment depression in the precordial leads. Okay. See the inappropriate concordance in lead V1 in patient with left bundle branch block. There is picture number A. Then inappropriate concordance in lead V6 in patient with the left bundle branch block, that is B. And the exaggeration of appropriate discordance in lead V1 in a patient with the left bundle branch block, which is shown in C. So this pattern should be in your mind. Now this picture shows the development of left bundle branch block in the same man shortly after admission. Note the ST segment depression in lead V3. This is an example of inappropriate concordance. You can go back in the video and then come back again to understand this concept. Right bundle branch block is most commonly seen in association with the coronary artery disease, but in many cases no organic heart disease may be there. Uncomplicated right bundle branch block usually causes little ST segment displacement and neither causes nor masks QA. Thus it does not generally interfere with the diagnosis of myocardial infarction, though it may mask a posterior myocardial infarction. The Brugada syndrome, which is familial, occurs particularly in young men and is characterized by right bundle branch block and ST segment elevation in the right precordial leads. There is a high instance of death as a result of ventricular tachyarrhythmias. Differential diagnosis of ST segment elevation. ST segment elevation has numerous possible causes. It may be a variant of normal or may be due to cardiac or non-cardiac disease. A correct diagnosis has obvious advantages for the patient but is also particularly important before the use of thrombolytic treatments so that unnecessary exposure to the risk of thrombolytic drugs can be avoided. The interpretation of ST segment elevation should always be made in the light of clinical history and examination findings. There are often clues in the electrocardiogram to differentiate the ST segment elevation of acute ischemia from other causes. For example, reciprocal changes may be present which strongly indicate acute ischemia. Serial ECG or continuous ST segment monitoring is also useful in ischemia. Ischemic ST segment elevation evolves over time. Old ECG are also useful for comparison. So serial ECG is very useful. So that was the presentation on myocardial infarction reading of ECG from Dr. N.S. Mani. Please visit the channel every day, www.youtube.com/acpgmed. Thank you.